trend, this downward trend kind of like accelerated, that was during COVID. So this window that we have in gray, where the largest closures happen, are actually at the time of the pandemic. And I'm also showing you there some changes in the regulatory framework for maternal health and for delivery. And we actually don't see any important relation between the regulatory framework and those trends, meaning that there's something bigger happening and that maybe the regulatory framework is creating some pressure, but that does not explain the whole picture of why these units are closing in the country. Now, importantly, this is something that we can also see some variation geographically. This should work, but it's not working. So, okay, so I'm trying to show you some maps, but I don't want to go all the way to the end. Sorry for this, because the hyperlink was not working. But just to show you how the geographical distribution has also changed dramatically during the past decades, we have here in the map that is mostly yellow to your left. These are, as of the end of 2009, the obstetric units that remain open since the beginning of the year. And as the color gets kind of like to a bluish purple, it means that a lot of units are closing. So you don't see a lot of variation precisely in that year. And I'm missing like the middle here in 2015, where you will start to see some of that yellow turning actually blue. And in 2023, you see that a lot of closures have been happening across the country and not just in some particular areas. Okay, so let me go back to my figure of trends. And so the question is, should we worry about these closures, in particular now that we know that there's a downward trend also in fertility, not only in Colombia, but globally. And we see this coming from two different cases. So the first one is, if you think about this from the efficient markets view, in which the survival of these units is determined by dynamics. So let's say that the ones that are closing are those that are lower quality, or because there is lower fertility in those municipalities, or they are using some depreciated techniques. Then in that scenario, you would think that patients are going to be better off because we're actually losing the worst units. Those are the ones that are closing, and the ones that are remaining are the ones that are going to provide good services. But it could also be the case that even in that scenario, if the system cannot really absorb that extra flow of patients, there could be some congestion related to what Angela and Paul were presenting before. And then that means that even in that scenario where closures are kind of like efficient, patients can be worse off. The second case is that if you think about this from the inefficient markets point of view, where the survival of the units is not uniquely determined by market dynamics, it can be the case that like high quality units are also closing. So that was the example of these hospitals San Vicente that I was showing you at the beginning. So it's not necessarily that those that are worst in the services are the ones that are gonna disappear. And it can be that actually the ones that are more constrained are the ones that are not gonna be able to close. So in that scenario, we think that the absorption capacity are gonna make patients to be worse off on average. So we think about these as being beneficial or detrimental, depending if there is sufficient capacity of the units, depending on the characteristics of the units that are closing, and why are they closing, so the reasons behind these events. So what we're going to do in this paper is to start by showing you what I already did, which was the concerning trend of closures across the country in these units. We have been focusing on distinguishing between obstetric closures, gynecological services, or both, and we see some differences. So typically, gynecological services tend to remain more stable than obstetric units. And we contrast these trends with other services, and we are actually seeing that this is something that is unique to the case of OBGYN services. And then we are also going to estimate the effect of these closures on a different set of outcomes for maternal health and also for infant health. And what I'm going to show you today just focuses on complications at childbirth. And we're going to divide those complications into complications at delivery, complications because of care, and complications because of congestion. And in the paper, we are also aiming to explore other outcomes such as labor force participation and earnings for these mothers. Now, in addition, we also want to talk about congestion. So like if these units are closing and then this is diverting patients to high quality services that are now going to have to take these inflow patients. We want to answer if this is creating even worse outcomes for the remaining patients in their initial units. And if this is leading mothers to change the choice location, but also the method they are using for delivery. So we think that this paper contributes to 3 different strands of the literature. The first one is about healthcare access barriers. And here we see this paper fitting with the studies that have found that even if we have universal coverage, this doesn't necessarily mean that we have effective access. And this is, there's some evidence for developing countries, but also recent work by Juliana Londoño for Colombia. And there's also barriers to access that seem to be more acute in developing countries because of fragmented structures and unequal distribution of providers, which means that these barriers are going to be more important in the context of Colombia. And we already know from high-income settings, from evidence for Sweden and from the US, that disclosures, because as I was mentioning before, this is a phenomenon that is happening worldwide, disclosures may shift patients to better facilities, but they can also worsen maternal morbidity. So even in the context of high-quality services remaining open, this can lead even to some detrimental outcomes for mothers, regardless. And we are gonna contribute to this literature by estimating the effects of disclosures in a system where there is guaranteed access, but there is uneven availability. So as I was showing you, the distribution of services is not equal. And even these partial reductions in the supply of services can lead to complications and lead to changes in the care-seeking behavior of mothers. The second strand of the literature is on congestion. So we know from, again, work for Sweden and from the US and other countries that congestion in hospitals can lead to delays, to lower quality care, and substitution between procedures or even professionals, even if it is happening among high-performing facilities. So in our context, we think that the extent to which these redirected patients can generate congestion remains an empirical question in this fragmented framework with uneven access, and we try to understand in this paper how these closures can affect nearby hospitals through congestion spillovers. And the last is on maternal health outcomes. So unlike previous work that has focused mostly on neonatal outcomes, we are gonna explore a larger set of outcomes for mothers. So we are looking into immediate effects, such as delivery complications, and also medium-term impacts into maternal and infant health. And as I mentioned at the beginning, we also want to take a look at what's happening to labor market participation for women who are experiencing these closures in the services. So I'm not gonna go into the details that Paul and Angela had already shown you, but I'm going to focus mainly on what we care about for this paper, which is how does it work in this context in Colombia for maternal health. So we know that insurance assigns mothers to a primary care provider based on network availability and proximity to the residents. And if a closure happens, so if they lose their care, the insurer has to assign mothers to delivery in the closest available service within their network. So we're going to try to use these rules for identification of the closures. And we see this as in a complex system in crisis. So we are still working on understanding more about the reasons why these closures are happening, but we know that obstetrics in particular have become very low profitable services. There's a lot of new regulations that means that for providers it's more difficult to deliver these services with the quality standard that is expected. And there's also some infrastructure challenges that are putting pressure in this particular service. Okay. So in terms of the data we're going to use to identify the effects of the closures, we are using RIPS, which is the same records that Angela and Paul already mentioned. And in addition to RIPS, which are the register of individual services, that this is for patients, so we have all the records for patients. We also have records for the institutions. So we are going to use operational records for the universe of healthcare providers from 2015 to 2023. And in those records we have the opening and closure dates of these services and where they were providing the services. So the municipality where they were operating. We also have some information on installed capacity and some financial information that we are still processing. So in terms of maternal health outcomes, we are gonna classify complications at delivery based on ICD-10 classification. We also did some work with experts in the field to reclassify complications to have a bigger set. And we also have complications due to congestion and due to practice. So just let me give you a couple of examples of complications at delivery and what we mean by that. So there we have problems such as eclampsia, fatal injury, hypoxia, obstructive labor, hemorrhage, some different things that can happen during delivery that are considered complications by experts in the field. In complications in care, we are working on classifying events that happen that are associated more so with medical errors, and then some complications due to congestion, that wouldn't have happened in the absence of maybe having less available professionals to provide the services. We are also going to look to severe maternal morbidity, postpartum depression, and other outcomes that we have not yet looked at, as I was mentioning. This is work in progress. So for delivery, these records also allow us to identify where the mothers gave birth and the method that they use, and the treatment is going to be defined from the operational records that I was mentioning before. So what is the idea for the identification strategy? And here we are going to try to exploit this network configuration that we have in the country. So suppose you have the mother's principal care provider. So this is this here. This is just a toy example. And the mother, we see that in the records, she is going to these units here for procedures or other medical consults. So this is going to allow us to infer the zone of residence of the mother. And we need to do this because we don't actually know where mothers live. This is not available in the anonymized records that we have. So using kind of like the record of services that they have used, we can infer what is the relevant zone of residence for them. And the idea is that we can identify the closest unit to that revealed zone of residence. And in the scenario where the unit closes, we want to also examine if they have other options available within their own network. Because the idea that Paul was saying is important that for patients that the services they can use are within their network. So we also want to control for whether or not these closures are happening broadly in their network or is only a partial, let's say network closing. So then with that variation, we are going to estimate event studies similar to what Angela was showing you. And here we're going to try to compare what's happening to the maternal health of women who are experiencing disclosures versus those who are not. And because of recent advances in the literature, we're also going to estimate this using the more recent alternative estimators for difference in differences. So this is some preliminary evidence on changes in the services provided at the institutional level. So using this definition of treatment that I was mentioning, we want to see this effectively leads us to see in the data that there's lower provision of services for women. And what I'm showing you here is at the institutional level, the probability of providing services for pregnant women. This is this first figure here. This is for providing services for women in labor and in delivery. And you see that the decrease after the closure is of about 10 percentage points in that probability. For pregnant women, that means it's about 20% of the control mean, while for labor and delivery, that's a decrease of 60% in these services. So this is actually leading to a change in the provision of services after the closure. We are also seeing that at the individual level, mothers are visiting more hospitals after their service closed. And this is something that we had seen in the past in like reports from news outlets, mentioning that because of the closure of units, women actually have to seek care in a broader set of other providers, and they usually have to like go from one to the other to try to find the appropriate care that they need. And we see that actually there's an immediate increase in about 0.5 more visits to hospitals in the last trimester. Now, in terms of complications, we are seeing some suggestive evidence of an increase in complications at delivery and in care. And here we split our set of closures for like pre-COVID closures versus post-COVID closures. And the reason why we did this is that we think that the reasons behind those closures that happened before COVID are very different to the ones that happen after COVID. So we think that the first ones might be more in line with this idea of efficiency, so maybe those units were actually lower quality versus the ones that are closing after COVID that seem to be more about financial reasons and pressure from the system. And we don't see any significant results here, but as I'm saying, some suggestive evidence of an increase in complications. Now, we think that these results, that the lack of results in complications actually stem from us not having yet fully mapped the network for mothers. So what I'm showing you here doesn't incorporate this idea of the networks available. Once we have that, we expect to see more clean results on these dimensions. But the second reason is what I was mentioning before, and in line with what Paul and Angela showed you before, we think that there's a lot of heterogeneity depending on how big these closures are, leading to congestion or not in the municipality where these women live. So next, what we are doing is to focus on 3 different scenarios. So suppose this first scenario here, this is going to be a partial closure. So you have 2 women that had 2 initial services and they are losing just 1 unit in their municipality versus a full closure where women are losing all of the available services in their area. And we're going to compare those 2 cases to the case of no closures for women. So what we would expect is that if there's any evidence that this is driven by congestion effects, that the effects on this group are going to be relatively larger to the ones of the partial closure. And we plan to estimate this with an event study specification, distinguishing by where the municipality where the women lives is experiencing a partial closure, so not all of the units are disappearing, versus a full closure where all of the units have disappeared for mothers. So we don't have the results of this yet, but I can show you effects on complications at delivery when 75% of the services in the municipality closed. So this is the graph that I have here. And what you see is that after 75% of the services in the municipality closed, there's an increase in complications at delivery of about 5 percentage points right after. So this is indicative that, for us, that this is driven mostly by this idea of congestion, also on spillovers, driving worsened health outcomes for mothers and for their health. And I finished a bit earlier. I didn't want to run into your lunch, so this is it for today. Thank you very much.